I hope you're excited to dive deeper into advanced lipid testing. Hello to all of you from all over the world. So let's get into it. Here are our performance objectives. Our first performance objective is to identify the strengths and weaknesses of the current AHA-ACC guidelines and risk calculator for managing dyslipidemia. So get ready. I want this to be really interactive. So get your fingers ready, get in the chat box, and real quick, if you can chat, who here understands the 2018 AHA-ACC hyperlipidemia guidelines? Say, yes, I do. No, I don't. None of your business. I might not. But go ahead and chat. Put something in that chat box. Who understands those guidelines and who does not? In functional medicine, we want to know the guidelines. We want to know exactly what the guidelines say and why the guidelines are there. And if we didn't know the guidelines, then that would be irresponsible. Responsibly, we understand the guidelines. So if you ever waver from them, you know why, and you know why you're doing it, and you can explain it. So if you look at the new guidelines emphasize lifestyle therapies for everyone, which was good. I feel like it was more of an emphasis on lifestyle therapies. It encouraged more patient involvement in decision making. It added a more extensive list of what they called risk enhancing factors. So no longer just looking at standard lipid panels, you have these risk enhancing factors that increase someone's risk of hyperlipidemia or of cardiovascular disease. Its main emphasis is still statin medication. It did not start with low intensity statins. You start with either a moderate or a high intensity statin. So there's no start slow and increase. It's like go right to a moderate, go to a high, or go to a high intensity statin. It did bring back some LDL goals. In the previous guidelines, they actually just said, don't look at LDL once you've done the risk calculator, put them on the statin and forget about it. And it discussed some non-statin medication for specific groups, mainly mainly Zetia or ezetimibe and the PCSK9 inhibitors. So the risk enhancing factors that introduced, this is actually a good thing for functional medicine because a lot of the advanced lipid tests that we're looking at are looking at these things. A lot of our evaluation are looking at these things when our conventional medicine colleagues weren't even looking at them. And now this kind of shows their importance and brings it to the forefront as part of the guideline. So what are those risk enhancing factors? You have a family history of premature atherosclerotic cardiovascular disease, high risk ethnic groups, lipoprotein A, persistent elevation of triglycerides greater than or equal to 175. So it reminded us that high triglycerides are a risk factor for cardiovascular disease. Persistently elevated LDL levels greater than 160 or greater than or equal to 160. Lipoprotein B greater than or equal to 130. So it also mentioned high sensitivity CRP as a risk enhancing factor. Many are checking high sensitivity CRP as part of our panels. It mentioned chronic inflammatory disorders. It mentioned an ankle brachial index less than 0.9, metabolic syndrome, which from the last lecture and next lectures, you'll know metabolic syndrome is extremely important to get to the bottom of. Chronic kidney disease, and radiation therapy, mainly radiation therapy in the chest area that can radiate the coronaries or radiate the heart. So our first part of this objective was to identify the strengths of the guidelines, and then we would go over the weaknesses. So what are the strengths of the guidelines? It does help us identify the highest risk individuals. It reiterates importance in lifestyle modifications. It reestablishes lipid levels, like I mentioned, that they said just start them on a statin before, and in the 2013 guidelines, just start them on a statin and don't even check anymore. And now they're saying, no, that kind of doesn't make sense. We should be looking at lipid levels. It acknowledges these risk enhancing factors, which now if somebody tries to say, hey, why are you checking this? You can say, well, according to the guidelines, we're evaluating and we're looking at risk enhancing factors. And it encourages patient participation in their plan, when before it just said, hey, we recommend you go on a statin. Now you actually have a risk discussion plan. So now identify the weaknesses of the current guidelines. So what are the weaknesses of the current guidelines? And listen, it is not easy to come up with guidelines for hyperlipidemia that everybody can follow. You end up with 20 specialists and you get 20 different opinions. But in order to, I mean, it is what it is, we are where we're at, but in order to further look at this and look at the potential weaknesses, I want you to meet John here. John is a 55-year-old African-American male. His total cholesterol is 200. His HDL is 55. His blood pressure is 120/79. He's on amlodipine, 5 milligrams, POQHS for hypertension. He has no history of atherosclerotic cardiovascular disease, no history of diabetes, and he is not a smoker. Also, he happens to work out every day. He does cardiovascular exercise at least 5 days a week for at least an hour. He does resistance training 2 to 3 times a week. He owns a cat. He eats dark chocolate multiple times a day, and not like that generic high sugar or that name brand high sugar full of milk chocolate. I'm talking about 85% cacao or greater. If it's not 85% cacao, don't even bring it to him. He has a handful of nuts a day, but not with salt, because he doesn't want to have a whole bunch of salt. He knows that that increases his risk of high blood pressure. He gets 8 to 9 hours of sleep every night, and he wakes up feeling refreshed, ready to embrace the world. He's on a Mediterranean-like food plan. He's in a relationship with his wife, who he gets along with great. They have 2 dogs. The dogs get along with the cat. Like, it's the perfect life here. And he comes to you as a provider, and he's like, hey, what do you think? I mean, he knows he's healthy, but he's like, what do you think? Am I in good shape or what? So put in the chat box. Look here, this is his case. Put in the chat box. What do you think? Do you think he's healthy? You think he should be on a statin? Moderate, maybe a high intensity statin? Go ahead. Put your opinion in that chat box. So what do you think? What kind of shape am I in? You're like, hold on a minute, buddy. We must have our risk discussion. So you plug his data into the risk calculator. This is the required data that it looks at. So take a look at this. These are the points it's asking for. What's his age, his gender, his race, his total cholesterol, his HDL, systolic blood pressure. Is he being treated for hypertension? Is he diabetic, or is he a smoker? As you know, there's a whole bunch more risk factors, but for the risk assessment, these are the risk factors that it looks at. And you find out that his 10-year risk of heart disease or stroke, according to the risk calculator, is 9.5%. So you go through his risk enhancing factors. Remember the new guidelines, you go over risk enhancing factors, and he says, my dad had a heart attack at age 54. Remember, less than 55 is premature cardiovascular disease. So my dad had a heart attack at 54, but he didn't take care of himself. Obviously, he's taking care of himself. His father didn't. So what would the recommendations be based on the AHA-ACC guidelines? Discuss treatment options, and if he's agreeable, start him on a moderate intensity. It would have told him to start a statin. Would have told him to start a statin, but it would not have told him to have a risk discussion. So weaknesses of the pooled cohort equations. It looks at age as a risk factor that dominates the scoring. So the older you get, the higher your risk. Now, people age differently. You could have somebody that is older or that is aging while they are exercising and they're staying healthy. And then you can have people that are aging that are smoking cigarettes and eating potato chips the whole time, and they're not exercising. So it looks at age as like dominates this score. It does not look at mortality data. It just looks at heart attacks and strokes. But what if there's more attacks in the people or what if he'll have heart attacks, but he won't die of the heart attack? And it doesn't take into consideration other treatments, like what is he eating? Is he on a healthy food plan, or is he on a junk food plan? Is he exercising? Is he on aspirin? Does he take blood pressure medicine? Because that can lower your risk of cardiovascular disease. And using the relative risk, it uses relative risk instead of absolute risk, and that can be misleading. So are you all ready for some math? Put in the chat box if you're ready or not. Just say, I'm ready, I'm not ready. So get ready to put in your chat box something else. Who can calculate absolute risk? Say, yes, I can, no, I can't, none of your business. But put something. Who can calculate absolute risk? Who can calculate relative risk? Who can calculate number needed to treat? And I want you to pay attention to what everybody's chatted. I just made your job easier. One of the beautiful things about these live conferences is that we get to network and meet other like-minded people in our tribe. And we get to pick at, you always want to make a couple of really smart friends when you have this conference. And the people that said yes to all of those things are your really smart friends. So make sure that you friend them and make sure that you reach out to them and you invite them for a brain date. And I hope everybody is setting up brain dates, by the way. So what is the difference between absolute risk and relative risk? Well, absolute risk is the risk of developing a disease over a given period of time. The atherosclerotic cardiovascular disease risk over 10 years, for example, where relative risk is used to compare the risk across two different groups of people, a smoker versus a non-smoker, someone that's on a statin versus someone that is on a, or off a statin versus on a statin. And this interpretation can be misleading. So if you look at our patient that has a 7.5% risk of having a heart attack or stroke in the next 10 years, on a standard dose statin, it says his relative risk is a 29% reduction in heart attacks. 29 sounds like a big number. If he goes on a high dose statin, his looking at relative risk, it will cause a 43% reduction in heart attacks. Like I said, it seems like a big number, but if you look at it, so look at the chart here. If he's on a standard dose statin, his risk will go from 7.5% to 5.5%. That's only a 2% different. But his relative risk, statin versus no statin at all, is 29%. So it's 29% different. So when you say you have a 29% reduction, it means something completely different. If you look at the number needed to treat here, number needed to treat is 50. 50, that means that for every 50 people that you put on a statin that have his numbers, 49 of them will not get a benefit and one of them will. So 49 of them still have risk of the side effects, they just don't get the same benefit. And if you look at the high intensity statin, his absolute risk is 4.5%. So it's only 3% off from no intervention at all. But his relative risk is 43%. And then when you tell a patient you have a 43% reduction of cardiovascular disease, they're like, whoa, that's a big number. Number needed to treat is 33. So for every 32 people that go on the high intensity statin with his numbers, or for every 33, 32 of them have no benefit from it, but can get the risk of the side effects. And only one of them, you'll get one less stroke and heart attack. And we don't know if that means if that person is going to die of the heart attack and stroke or not. Or will somebody die of being on the statin? We don't know that. So in order to help us with this process and in order to help make this decision, what we recommend is using Mayo Clinic's statin decision aid. And this statin decision aid, and this is the website. So if you check out the website, or if you put in your internet browser, just put Mayo Clinic statin decision aid, and you'll find the calculator. And what I recommend is making this a separate visit. So it is too hard to do everything in one visit. And I hope you guys by now know this. I hope by now you guys have realized this. What happens is a lot of times there's so much data that we have to process with the patient, and even if you spend an hour or 2 hours, they can't comprehend that much all at once. It needs to be small little bites of information. So what I would recommend is say, hey, listen, I want to take a look at this situation a little bit more. Let me see you in a couple weeks, and we're going to just focus on your cardiovascular risk. Even though you went over their labs and everything else, now you're going to focus, you're going to look at their actual number risks. And so, like I said, I would recommend doing a separate visit. So if you take a look at our 55-year-old patient using the tool, and you plug in his information, it basically says that 9 people will have a heart attack in 10 years if they do nothing, and 7 people will have a heart attack if an intervention happens, if they end up going on a standard dose statin. And from that, you can tell the difference is 2 people. So 2 people will be saved from a heart attack. So what you can do with that is you say, okay, well, 2 people per 100, that's 1 person per 50, your number needed to treat is 50. So you can tell the patient that, listen, if for every 50 people that go on a statin that have your numbers, you get 1 less heart attack. And that person may not die of the heart attack. That means a little bit more than saying, hey, you have a 33 or a 35% reduction of cardiovascular or of a heart attack. And then when you put it through what it shows, it's going to show you cost, it's going to show you side effects. So the patient you recommend going on a statin, and the patient's like, yeah, nah, I don't think so. And you say, you're confused, and you're like, you know what we could do? We can do a coronary artery calcium score, because that can help us risk stratify. And he asks a very smart question, which many providers don't ask. What are the risks of doing a coronary artery calcium score? And what is the risk? Radiation. So if you look at it, 3 millisieverts of radiation per coronary artery calcium score, and there could be a 10-fold variance. So somebody could have 10 times the amount of radiation if they're not doing it right at the center. Take a look at how much an X-ray is, 0.1. So when you go from 0.1 to a coronary artery calcium to 0.1 millisieverts getting a chest X-ray, to 3 millisieverts doing a coronary artery calcium score, which you may want to do, which according to guidelines you can do every 5 years. Take a look at that, and who can calculate how many times more radiation do you get from a coronary artery calcium score than a chest X-ray? Meaning, how many chest X-rays would it take to get the same amount of radiation? Go ahead and do your calculations and put it in the chat box. There is a very nice tool. It's at xrayrisk.com. I recommend that you use it. I recommend you check it out, because what can happen is you put in whatever test it is that you want to do. You can type in how many times they did the test and the radiations, and it can give you a cancer risk to discuss with patients. When I have a patient that's getting frequent CAT scans and other radiation tests, and they're like, we're concerned about radiation and want to know if they need to back off, talk to their specialists, I'll set up a separate visit. I'll type all this in that visit, and we'll have that discussion with them. So you tell them, he asked about, hey, is there any side effects? You're like, just a little radiation to make your urine glow in the dark. And he's like, nah, I'm all right, because I have perfect vision. My vision is I can see in the dark. So you tell them, no worries, here is a handout. This is the cardiometabolic food plan that I got trained in from the Institute for Functional Medicine, because that's how we do things. And he takes that plan, you go over some highlights, and he goes, I don't care what they say about you, you're all right. Happy end of a visit. So you document in your progress note, hyperlipidemia, I explained risks and benefits of statin therapy. I went over Mayo Clinic's statin decision aid tool. We discussed number needed to treat and we discussed number needed to treat as well as number needed to harm. We discussed risk factors and risk enhancers. We discussed lifestyle modalities as well. Knowing the risks and benefits, patient declined statin therapy at this time will continue to follow. If you don't document it, it didn't happen. You don't want somebody to later say, oh, no, if you told me that I could decrease my risk by going on a statin, or one of their family members saying, well, he was never told. Document, document, document. So what are some more weaknesses to the guidelines? They recommend a low-fat diet. People are different genetically on how they respond to fat, and there are different types of fat. You can't say all fat is the same. The main focus is total cholesterol, and we know the limitations of just looking at total cholesterol. The main tool is statin therapy still, and it would be nice for us to have some more options, and that's what you're doing here. So challenges with statins, early statin trials. So it's not as clear as you may think with statin therapy, or you may not think, right? You may be kind of woke, should I say. Early statin trials reported significant mortality benefits, but no one is really willing to look at statins versus a different intervention, like let's say dark chocolate, or like let's say exercise. It's because statins are considered standard of care. Everyone that is indicated to be on a statin is supposed to go on a statin. And for that reason, they don't do trials against statins. So that's challenging. That's a challenging barrier. If you look at the studies that were done that showed phenomenal results with statins, many of them were prior to 2005. And back then, there were a lot of questionable acts that these pharmaceutical companies were doing. There was accusations of biased results by pharmaceutical companies. Premature trial terminations happen, so they just start the study and they just end it. Who knows why? Underreporting of adverse events, so they don't report all the side effects that they possibly could have had in the intervention, and high numbers of patients were lost to follow-up. And if you look at this meta-analysis, just looking past 2005, from 2005 to 2016, what you'll see, they looked at about 71,000 people put on a statin, and this is for primary prevention, so they never had a heart attack in the past. And what they found for all-cause mortality, number needed to treat was 250. So 250, that means that for every 250 people that were put on a statin, you had one less death. But it's not looking at other interventions like diet and exercise and whatnot. So what about the side effects of statins? Well, statins are needed for hormone productions. Cholesterol is needed for hormone production. So if you give them statins and you're dropping cholesterol too low, are you going to have trouble making your cortisol? Are you going to have trouble making your sex hormones? Are you going to have trouble making vitamin D and vitamin K and CoQ10? Are you going to have trouble with bile salts? Are you going to have trouble with all of that? Yeah, if you start messing with the system, things can happen. Statins may increase the risk of diabetes. They may increase the risk of mild cognitive impairment and Alzheimer's disease. The studies are conflicted on that. They can increase the risk of neuropathy. They can cause muscle pain. They can cause atrophy. They can cause falling in the elderly. So low statins. Now, association doesn't mean causation. So association doesn't mean causation. So that doesn't mean that statins caused it or low cholesterol caused it, but low cholesterol is associated with preterm delivery, microcephaly, ischemic strokes, intracranial hemorrhages, atrial fibrillation, violent and impulsive behavior, depression, and increased suicide attempts, 7.33 time increase in men and 5.6-fold increase in women. So having low cholesterol might not necessarily be a great thing to have it that low. Other weaknesses, if you have an LDL greater than 190, they say go right to high intensity statin. Well, what about intermediate? What about a small intensity statin? What if they're just so stressed out because of this pandemic and because of what's happening in the world that their body thinks that it needs cortisol, so it is revving up cholesterol so the body can make cortisol? What if that's the issue and they were fine before that? Now you're going to put them on a high intensity statin for the rest of their life? What about other modalities and figuring out what happens in 10 years on a statin or 20 years or 30 years on a statin? What if it's slowly destroying their mitochondria? What about pathophysiology? What about getting to the root cause of and figuring out what's causing it? And what happened to individualized healthcare? And if you look at other therapies, now They're not the huge studies that the big pharmaceutical companies can afford to do, but looking at these associations, consumption of daily tea, green and black, can decrease your risk by 10 to 20% of cardiovascular disease and strokes. A handful of nuts a day can decrease your risk of cardiovascular mortality by 23%. Exercise 30 minutes a day can decrease your risk of cardiac events by 30 to 40%. And if you own a cat, there's a 30% reduction in cardiovascular deaths and strokes. Dark chocolate every day may decrease your risk, depending on how much you consume, by 45 and 77% of atherosclerotic cardiovascular disease, and much, much more. This weekend is going to be jam-packed with information, with pearls, with other modalities. And I just would say, stay tuned. Don't go to the bathroom except by bathroom break. You're at home, for God's sakes. Get a urinal next to you or something. Get a portable next to you. You are not going to want to go anywhere and miss any of this. And the good news is that you can listen to it again later and later and later, because you're going to get these recordings. So what are some practical recommendations from what we just were talking about? Know the guidelines. Know the guidelines, because you want to document. If you go away from the guidelines, you want to document that. That's what makes you a smarter provider. That's where people can't challenge you. But if you have no clue what the guidelines are and just say, oh, well, that's dumb or that's stupid, it's not going to win you. It's not going to help you legally. Use the Mayo Clinic decision aid tool. I think it's a very powerful tool. It empowers us and empowers patients to understand what these numbers really mean. Template your disclaimers so you don't forget to disclaim it, or to put the disclaimer in, and use the guidelines to motivate change. They don't have to be on a statin, but if you say, look, this is so bad that according to current guidelines, your risk is so high of having heart disease that they recommend you go on a statin drug. Oh, no, I don't want to go on a statin drug. Okay, well, then what can we do? What can we work on? Document that they refused, but use the risk factor, or use the analysis to motivate change. And now let's get to the second performance objective, which is recognize underlying risk factors contributing to dyslipidemia. If you take a cup of water and you pour oil in it, what is going to happen to that water? It is going to separate. The oil and water will separate because oil or fat does not mix well in water. But you need fat for your brain. You need fat for life. So how does fat go from your blood to the rest of the body? Well, it uses lipoproteins, and that's the part of the transport system in functional medicine. The basic testing of your lipoproteins is looking at a standard lipid panel. Almost everybody has had a standard lipid panel. So in the standard lipid panel, we look at total cholesterol. Not that useful, because you're adding up LDL, which can be harmful, and HDL, which can be helpful, and then throw in some triglycerides with an equation. It's not really as useful as it could be. LDL, either direct or calculated, and that LDL is responsible for taking cholesterol, carrying cholesterol, and taking it to the rest of the body, from the liver to the rest of the body. And that's what can squeeze in between the cracks and cause atherosclerosis or clogged blood vessels. It is, if it's higher, persistently higher than 160, or greater than or equal to 160, it is considered a cardiovascular disease risk enhancing factor. We have HDL. HDL is like the garbage truck. It pulls cholesterol out of the tissue into the bloodstream. So looking at HDL is beneficial as well, just from a basic point of view. And then you have triglycerides. You have free fatty acids plus glycerol mixed together. They're associated with insulin resistance. And this is a cardiovascular disease risk enhancing factor as well. Having a elevated triglyceride greater than or equal to 175. You're going to want to bring that down. So any patient that has these numbers out, you got stuff to talk to them about. You got stuff to work on. But there's a couple of issues, which brings us to a pop quiz. I hope you're ready for this pop quiz. You should have a widget pop up and be ready to take this poll. Are you ready? Let's go. Owning a pet decreases, or owning this pet decreases the risk of cardiovascular disease and stroke by 30%. So, A, a dog, B, a cat, C, a ferret, D, a Wookiee. Go ahead, answer the question. A dog, a cat, a ferret, a Wookiee. And when you answered the question, what I'd like you to do is I would like you to go into your chat box, and I would like you I would like you to mention, do I own a Wookiee? Do I own a ferret? I really want to know. I'm going to go back and I'm going to read these chats. I want to know who here owns a ferret. The first animal my wife and I owned together was a ferret. It was the most beautiful thing. Me taking that ferret down the road. I was so excited until I got laughed at a little bit, but I don't care. I don't care. I was happy. The ferret was happy. My wife was happy. So you see, like, this is one of those times where dog and cat lovers is, very good. Good answers, guys. Good answers. Thank you for participating. You 2% that said a Wookiee. I am not sure the statistics on Wookiee. Nobody said ferret. I kind of feel bad for the ferret right now, but the answer is a cat. Owning a cat. There was a study that showed that if you owned a cat, it decreased your risk of cardiovascular death and stroke by 30%. If they could, if the pharmaceutical companies could patent cats, believe me, they would. And the second question, what percentage of heart attacks leading to sudden death happen in patients with normal cholesterol? What percentage of heart attacks leading to sudden death happen in patients with normal cholesterol? And we have a different, you can put the percentage in. You can also put, at the end, you can answer no, because I don't want to say anything because there's been enough LDL shaming. We don't want to shame even LDL. I'm fed up. I'm standing up. Yep, okay, we got some 2% in there. Very good. But 4% standing up for LDL, strong. 50%. Good Lord, that's a lot. The 27.2. All right, we're at 3% LDL shaming. Very good. Thank you guys for answering the poll. And yes, 50% of heart attacks leading to sudden death happen to people with normal cholesterol. Wow. 50%. All of that talk and all of that push in conventional medicine about lower your cholesterol, and 50% of heart attacks leading to sudden death happen in people with normal cholesterol. What's the missing link? Standard lipid testing is not looking at the full picture. There's way more to the story. And that's why we're going to review this lipid metabolism in some more detail. So we'll start with HMG-CoA reductase. HMG-CoA reductase is the rate limiting step in cholesterol synthesis. This is what statins are targeting. Statins are going to block HMG-CoA reductase. HMG-CoA reductase, if you know that statins are going to block HMG-CoA reductase and lower cholesterol, what is going to happen, and feel free to put in your chat box, what is going to happen if you increase HMG-CoA reductase? If you increase it, cholesterol is going to go up. And guess what? Insulin increases it. And that's the connection. Why is it that eating higher amounts of sugar, why is it that eating higher amounts of sugar is going to increase your cholesterol? Well, because eating higher amounts of sugar, not balanced, is going to increase insulin, and insulin is going to push HMG-CoA reductase in order to increase your cholesterol levels. That's the link. So when somebody has high LDL, one of the first things I look at is, what is their insulin level? Now let's take a look at the LDL receptors. Normally what happens is LDL is going to bind to the LDL receptor in the liver. And the LDL receptor is going to internalize it into the liver, and then it's going to split. And then you're going to have the LDL is going to be broken down, and then the LDL receptor is going to go right back up, and it's kind of like it's like a fish net that can grab one LDL at a time, or a fish hook. So it's going to go back and go fishing again to pull more LDL out of circulation. So what happens if you don't have enough LDL receptors or they're not working? Your cholesterol is going to go higher. So let's take a look at PCSK9. PCSK9 is part of the proprotein convertase family. It's an important regulator of cholesterol metabolism. And what it does is it binds the LDL receptor as it's degrading, as it's pulling in the LDL, and it makes the body not only break down the LDL, but also the receptor. In the future, we'll be able to look at PCSK9 levels. Unfortunately, that's only like in research. We don't have the possibility in conventional labs yet, but in the future, we'll be able to see this. So now let's take a look at this. So look here, that the green thing in the picture, we don't know if they're really green, but I'm going to imagine they're green. That green thing in the picture is PCSK9 that jumps and it attaches to the LDL receptor LDL unit. And instead of separation and the LDL receptor making its way back up again, what happens is the body is going to break down the cholesterol and it's going to break down the LDL receptor. And now you have less LDL receptors. And if you have less LDL receptors, what's going to happen to your LDL? You're going to end up with more LDL. So your cholesterol levels will go higher. That's where the drug, the PCSK9 inhibitors come to play. And we'll go over that in a second. What can cause? So if higher PCSK9 can increase your cholesterol, what causes the PCSK9 to increase? A gain of function mutation. So genetically, some people just make more PCSK9, fibrates, and statins. So statins may lower your cholesterol in the beginning, but then they drop your cholesterol in the long run. So they may lower your cholesterol in the beginning, but they increase your cholesterol in the long run over time. So we got to think of long-term implications. Lipopolysaccharide-driven inflammation. Where do we get lipopolysaccharides? From dysbiosis or bad bacteria in your gut. So if you have bad bacteria in the gut, it can push the body to make PCSK9 and increase cholesterol. Oxidized LDL. We're going to talk about oxidized LDL in a bit. But if you have LDL, bad cholesterol, it can get oxidized. It can get rusted. And that rust or that oxidation will increase PCSK9. And then we have the PCSK9 inhibitors that are drugs, that are injections that you can add on top of a statin, or if people can't tolerate a statin in conventional medicine, so that you can lower cholesterol by lowering PCSK9. Now, there are natural PCSK9 inhibitors, and stay tuned. Dr. Guarneri's lecture is going to go over all different natural approaches for all of these biomarkers we're looking at. But berberine is one of the natural PCSK9 inhibitors. If you can type in the chat box, what are some other types of PCSK9 inhibitors? Go ahead, some natural PCSK9 inhibitors. And for extra credit, go ahead and post your PubMed link. So let's get back to LDL. The truth is, you heard it from Dr. Saxena. Size matters when it comes to the particles, right? So if you look at the person on the left and the person on the right, the person on the left has a LDL of 110. But what are we looking at? We're looking at milligrams per deciliter. This person has a whole bunch of really tiny LDL, small density LDL. The person on the right also has 110 milligrams per deciliter. All we're looking at is a weight in a volume. So the person on the left is high risk of having heart disease. The person on the right is not. Both of them have an LDL of 110, and that's one of the missing links. And guess what? We have a new interactive learning tool. You will find it in your course, the LDL particle size interactive. Congratulations. This program just keeps getting better and better. Congratulations to me. Now, I would prefer that you pay attention to the lecture and you start clicking on this interactive tool later, but make a note to yourself, interactive tool. So let's get back to production. Very low density LDL made by the liver becomes IDL and then LDL. What are the types of LDL? You can get small density LDL. This is a whole bunch of the tiny ones, which is higher risk. there's intermediate density, so kind of in the middle, and there's large buoyant LDL. A couple of notes on LDL, on small density LDL. Tiny density LDL can squeeze in the cracks a lot easier. Now, if you have inflammation, imagine the blood vessel lining, and the blood vessel lining, if the cholesterol penetrates it, it can form plaque in the right situation, in the right setup. So now imagine that you have inflammation and the lining, there's cracks in the lining. And then imagine that you have the really tiny bad cholesterol that can slip in the cracks easier. That's why it slips in the cracks easier, so it has a higher risk of causing cardiovascular disease. Higher sugar can increase small density LDL, but one of the thoughts about small density LDL is that it is a targeting molecule, which means if you have chronic infection, like a chronic tooth infection or osteomyelitis or chronic bad bacteria in the gut, the body's going to think it has to fight infection, so it starts making tiny LDL. And the tiny LDL goes and sticks to whatever it thinks it needs to stick to, like bacteria or whatnot. And then the white blood cells go and swallow them. Well, guess what? Now that tiny LDL is like floating all over the place. It goes into the cracks of the blood vessel, and then those macrophages start swallowing them, creating those foam cells, creating plaque. Small density LDL is associated with increased triglycerides, decreased HDL levels, and a 1.7 time increase risk of penetration of the endothelium. So 1.7 time increased chance of going into the blood vessel wall. There's an increased risk of oxidation or a rusting of small density LDL. When it rusts, it actually increases your risk. We'll talk about that a little bit more. And there's an increased chance of glycation. And glycation, what I tell patients, is caramelization, but basically of sugar. If there's an increase, if you have the small density LDL, the fact that the chance of sugar having an effect in caramelizing it is much higher, and the fact of it rusting is much higher. And both of those are risk factors for heart disease, and it is associated with an increased risk of coronary heart disease. There are two transformational changes that we should look at that increase the chance of LDL causing plaque: oxidation and glycation. We already mentioned them. Oxidation or rusting. So one of the markers of oxidation is myeloperoxidase. It's made by the neutrophils. So it really is a marker of inflammation and neutrophils, so that their white cells are going around doing something. But what it does, what the neutrophils are doing, they're releasing the myeloperoxidase, and it causes oxidation. So it causes that oxidative damage. High myeloperoxidase can lead to dysfunction of good cholesterol, or HDL, generation of atherogenic lipoproteins, and lipid peroxidation, where the lipids end up getting rusted or getting oxygenated. So, or oxidized, not oxygenated, oxidized. So oxidized LDL. So we can look at myeloperoxidase. We can also look at oxidized LDL. We can specifically look at oxidized LDL. So oxidized LDL is going to change the tone of the blood vessel wall, and it's going to cause endothelial damage. It will cause more monocytes and macrophages to make their way in, and it increases the chance of those macrophages to come in and swallow the LDL. And it increases platelet aggregation, so it increases the chance of clotting. You also, when you have oxidized LDL, one of the things that can happen is we can make autoantibodies, antibodies that our body makes that attacks the oxidized LDL. And that's one of the big markers of having a heart attack or stroke, when you start getting anti-oxidized LDL antibodies. Can't check it in the lab yet. You can do it in experimental labs, but when you see that oxidized LDL, you know that this person has an antioxidant imbalance, and there's something that needs to be done. F2 isoprostanes, these are lipid measures of oxidation of fat. So they're associated with atherosclerosis, Alzheimer's disease, and pulmonary disorder. So it's also a marker we can do looking at oxidation. Remember, I said there's two transformational changes. One was oxidation that changes the way that LDL looks like. The second one is glycation. Glycation is the term, the lay term is caramelization. Basically, what caramelization is when sugar is binding to a protein and it's caramelizing or caramelizing. I don't know how you're going to put this in the chat box, but I'd like you to comment in the chat box. Use transliteration if you have to. Is it caramelizing or caramelizing? And I guess it all depends on where you're from. So mention where you're from as well. So the indirect measure of glycated LDL is hemoglobin A1C. So hemoglobin A1C is looking at that protein, hemoglobin, that's found in our red blood cells, and it's seeing how much of it has been changed by sugar. Because we can't look at the glycated LDL yet readily, it's not readily available in the lab. When you look at a high hemoglobin A1C, just know that the other proteins in the body, including LDL, are also getting this caramelization. And so so this is one of the reasons that you definitely want to drop your levels, your hemoglobin A1C levels. So let's move on to apolipoprotein B. So remember, when we looked at the LDL and we looked at it binding to the liver, to the LDL receptors, and the liver taking that in, well, guess what? It's the apolipoprotein B, that was the binding site. That's where it binds. It's the primary apolipoprotein of chylomicrons, VLDL, IDL, and LDL. There's one on each particle. So because there's one on each particle, it's a nice way that we can see what the load is. If you see, remember, you can have an LDL of 110 and you have a whole bunch of really tiny ones, or you have a few of the big fluffy, both look like 110. But if your lipoprotein B is high, that's telling you there's a whole bunch of particles there. Its elevation increases your risk of heart disease by 2 to 3 times. And it is also, if your apolipoprotein B is greater than or equal to 130, it is a risk enhancing factor according to the new guidelines. I want you to be aware of this condition. Some people will say, oh, your cholesterol is okay. I don't need to check an apolipoprotein B or an ApoB. We just call it ApoB for short. Well, there is a familial variant where some people will have normal looking cholesterol, but their ApoB is really high. And that increases the risk of cardiovascular disease, and that should be treated and taken care of. What about HDL or high density lipoprotein? Remember, these are the garbage trucks that grab the LDL or the cholesterol or the garbage and pull it out of the blood vessel and bring it back to the liver. It helps protect the heart. It has cardioprotective effects. There is a component of it called ApoA1, and that component is what pulls the cholesterol out. So if your ApoA1 is low, then that means that yes, you have the garbage truck, but it is not good at pulling cholesterol out and putting it in the garbage truck. You can look at HDL particles, so you can see how many HDL particles you have, particle number, and just like LDL, you can have really big garbage trucks, or you can have really tiny garbage trucks. The bigger the garbage truck, the easier it is for that garbage truck to load up and to pull cholesterol out of the blood vessel. So if you look at it, when you look at the panel, the HDL2 is the larger garbage truck, whereas HDL3 is the tiny ones. The tiny ones are cute if you're playing a little car game with your kids, but the tiny one is not cute if you're trying to do something in your body, meaning pull that cholesterol out of the blood vessel. What about heavy metals? We know that heavy metals also increase your risk of dyslipidemia. It can increase the risk of cardiovascular disease. If you could mention, has anybody been to the detoxification and biotransformation module? Has anybody done the IFM detoxification biotransformation module? I believe now it has a different name. It's the environmental module. If you have been to it, put it in the chat box. If not, then I know you're going to want to go to it. If not, go ahead and put in the chat box. I'm going to do this thing. I'm going to make sure I find out about detoxification biotransformation, because that's just going to make me so much smarter. Nitric oxide and angiotensin II must be in balance. Nitric oxide causes vasodilation, antithrombotic effect. It can help with platelets. It stops platelets from sticking so much. It can cause growth inhibition, it can cause anti-inflammation, and it has antioxidant function. On the other side, you have angiotensin 2. Angiotensin 2 causes vasoconstriction. It causes adhesion molecules, prothrombotic growth promotion, pro-inflammatory, and a pro-oxidant response. Later, one of the lectures that I will be giving is one on COVID-19 and ACE2 and the implications of COVID-19, ACE2, bradykinin. Make sure you stay tuned, because one of the big things that causes COVID to make people so sick is that it makes angiotensin 2 go up really, really high. Stay tuned. Some cool stuff coming up. So why did I mention nitric oxide? Because ADMA is going to compete with arginine to make nitric oxide. So if your ADMA levels are high, then your arginine cannot bind to eNOS, endothelial nitric oxide synthase. And if it can't bind to eNOS, it can't make as much nitric oxide. If you don't have that nitric oxide, it increases its strength, it increases the tone of the blood vessel and increases chances of getting cardiovascular disease. And here are some things that affect ADMA, because basically you want your ADMA to be low, and you want your, so if you look at it, if your ADMA is low compared to your arginine, and you can check ADMA arginine levels, then you can do things about it. So increasing NRF2 can decrease ADMA. So resveratrol, EGCG, go ahead and put in the chat box what EGCG stands for help your colleagues out. And then sulforaphane. Those things are going to help upregulate NRF2 to decrease ADMA. Exercise and tight glycemic control. So really making sure that your blood sugar levels are low. ADMA is increased by proton pump inhibitors. So I did a TEDx talk a couple of years ago called "Is the Gut the Gateway to Disease?" And I mentioned a case of somebody who went on a proton pump inhibitor and then later had a heart attack. And the case that I mentioned 3 cases, but the case I was trying to make is that you go on that proton pump inhibitor and you stay on it, it increases ADMA, apart from all the other things they do. And what ends up happening is your ADMA goes up and it can cause atherosclerosis. So oxidized LDL can increase ADMA, and diets poor in arginine and in folate as well can do that. So what about TMAO? TMAO is a small colorless amine oxide. It is made from choline, betaine, and carnitine, which is mainly found in animal protein or animal products. And what happens is that specific type of bacteria in the gut, not everybody has them, but specific type can make TMAO from these things. TMAO is readily absorbed in the diet. So when you eat fish have a lot of TMAO. Your TMAO level is going to go high if you eat fish. Gut bacteria is going to change TMA or it's going to create TMA, and then from those amino acids, and then the liver is going to oxidize it and make TMAO. So elevated levels of TMAO has been correlated with a risk of cardiovascular disease. You got to be careful, and you got to make sure that if you're going to do this test, that they didn't have fish at least 24 hours beforehand and they skipped the last night's dose of their fish oil, because otherwise it's going to give you a falsely elevated TMAO. Now, there's a little bit of a paradox, and it is, and I think I have an explanation, but because they were saying that TMAO is so bad for you, it increases the risk of cardiovascular disease, but there's a correlation between consumption of lean white fish that are really low in fatty acids that are high in TMAO, and when they do that decreases your cardiovascular lipid risk. Some research indicates that it's not the TMAO, it's the TMA that's responsible for the cardiovascular damage. It's still in the air, but we do know that it is associated, high TMAO is associated with higher formictides to bacteroides ratios. And what you're going to want to do is you're going to want to flip it. So if you look over to the right, you got your choline, your betaine, and your carnitine, that certain pathogenic gut bacteria will change those into TMA, and TMA will, through the liver, will become TMAO. And the TMA may be toxic, the TMAO may be toxic, but the fish studies kind of make it a little bit weird. It might just be TMA, or it might just be an indication that you have bad bacteria in your gut, which causes multiple risk factors for cardiovascular disease. Not only TMAO, it increases inflammation and other things that we've spoke about already. So this is how I use TMAO. I look at it as a marker for cardiovascular disease caused by bad bacteria in the gut. I make sure that the patient is prepped. I make sure they skip their fish oil. Realize that the half-life of EPA is 70 to 89 hours. So you don't have to take your fish oil multiple times a day. You're good taking it once a day if you can get that much in you. Usually I'm going to take it twice a day because I don't feel like taking all those pills at once. But anyway, just understand that, and I wouldn't go too crazy. You can play around with things to try to lower it, work on the gut. But because it's kind of up and down and in the air, I wouldn't rely 100% heavily on it. Just look at it as a clue, but don't get too dogmatic about it. You have endothelial progenitor cells, and basically these can get exhausted, and what they do is they help repair the cardiovascular system. And if they're low, it increases your risk of getting a heart attack. Clinically, hyperbaric oxygen may increase the endothelial progenitor cells. Unfortunately, there's no quick way of checking these. It's just, this is more theoretical, just so because at the end I want to kind of mention how it all flows together. Lowering ADMA can increase them. So like we talked about, go back to the ADMA slide on how to lower it. L-theanine, which is found in green tea, may help, and statins also may increase endothelial progenitor cells. So one of the cases they make for statins is that by increasing endothelial progenitor cells, maybe that's part of the effect that they have. But like I said, it's not part of a panel yet. We also have BNP and N-proBNP. So BNP is a natriuretic hormone. It is secreted by the heart. It's released when the heart is stretching too much. The heart releases it to help people kind of pee out the extra fluid. It's high in heart failure, but you can have people that have high proBNP and they don't have heart failure. But it is a risk. When you have it, it does predict, if it's high, it increases your risk of death and cardiovascular events, even if you don't have heart failure. So a couple of things with this: when I see somebody with a high proBNP, I'm going to think, what would increase? Definitely, I'm going to do an echo and see what the chambers are looking like and the ejection fraction. But I'm also going to I'm going to look for what can increase strain on the heart. Atrial fibrillation, ask for palpitations, thinking about it, doing a 24-hour Holter monitor. Also, screen them for sleep apnea, because when they have those apneic attacks, it overworks and overstresses the heart. So those are two things that I would look for. So inflammation, you have high sensitivity CRP. It's considered a risk enhancing factor due to the new guidelines. And then you have LP-PLA2, which is also, it's a more vascular inflammation marker. Both of them are going to, either, if you have one or the other high, that's telling you that there's something going on inflammation-wise. If they're both up, then that is a much higher, they have a much higher chance of having strokes and heart attacks and whatnot. So when they have high inflammation, you're always going to want to look at underlying causes, poor dietary choices, lack of exercise, visceral fat, chronic infections, toxins, poor sleep. You know, this technology is not like that new. It's been around for a long time. As a matter of fact, when I was in internal medicine residency, I remember asking one of our top cardiologists, hey, I'm reading about CRP being an issue, high sensitivity CRP being a risk factor. Why don't we check it? He says, because there's nothing to do about it. And that was it. Well, if you know what's causing it, or if you know what could cause it, in functional medicine, we're going to do all the things we can to decrease it. But I'm sorry that it's not just give one drug and then follow it. Because to him, it's you just give a statin, it may lower it, it may not, and then there's nothing else we can do about it. But that's far from the truth. Poor sleep. If they have poor sleep, it can increase their inflammation levels. So we're looking at all this information, and listen, you're not, if this is your first exposure, don't worry about it. You learn one thing at a time. You start doing advanced lipid testing. You go back to your notes. When you're driving, if you have a commute, listen to these recordings as you're driving. When you're in the bathroom, why not multitask? Don't just sit in the bathroom and do nothing but use the bathroom. Listen to the lectures. Let your spouse think you're crazy. But anyway, yeah, don't do it too long. You might get hemorrhoids. But that's another issue. I guess that's part of the cardiovascular system. But don't worry if when I first was exposed to this, it was so overwhelming. I didn't think I would ever be able to be where I'm at now. I didn't think I'd ever be able to navigate it. But you can. If I can do it, I'm sure that you can do it. But just hang in there. So how's it what are we working towards? If you have dyslipidemia, if you have abnormal lipids, it can lead to endothelial dysfunction. So the lining of the blood vessel is not working as well. You can have oxidative stress, and then you can start to form plaques. So cholesterol starts going into that blood vessel wall, and you start to make plaque. If your blood pressure is high, it's going to drive cholesterol higher in between those cracks. If you have inflammation, inflammation is going to make the endothelium more permeable. So if you're inflamed, then the blood vessel lining is going to open up a little bit more. And small density LDL, if you have really tiny bad cholesterol, it's going to squeeze in the cracks, and it's going to squeeze in the cracks a lot easier. So what happens then? LDL can continue to get oxidized. So it continues to rust, and it continues to get glycated. So it continues to get caramelized. This marks it for macrophage phagocytosis. So then the macrophages come and start to swallow them more, and it creates a potential autoimmune target. And so basically then the body starts making these antibodies to these LDL products. And then now you have antibodies coming in and attacking in the fray. Foam cells are created, which are those macrophages filled with fat, and they increase plaque formation, and that creates more CRP and more LPPLA2, which makes the process even worse. And then your oxidized small density LDL is going to cause even more endothelial dysfunction. Those endothelial progenitor cells are going to try to repair the wall, and they're going to start to get depleted, and there's going to be less and less chance of repairing the wall. Having high homocysteine and other toxins can increase the plaque progression. So you have these toxins in the blood, like TMA or homocysteine, that's going to cause it to be worse. And then oxidized LDL levels will continue to increase and cause a T helper 17 Treg imbalance. Go ahead and put in your chat box, what does it mean when you have high T helper 17 and low Tregs? Go ahead and put in the chat box. So basically, let's see what's in that chat. Don't worry, I'm going to check and see what's in that chat box. So basically, it's marking you for autoimmunity. Antioxidized LDL antibodies then will start to form. How does autoimmunity happen? Well, it happens through molecular mimicry. So now let's take a step back. So what I described is that there is a cardiovascular process that is, or there's a process, a plaque forming process that's happening that's leading to autoimmunity. Think about our autoimmune patients. Think about people with lupus. Think about people with thyroid, with Graves or Hashimoto's. Think about all of the autoimmune conditions out there. What causes autoimmunity? Why does it happen? Well, when T helper 17 goes up and Tregs go down, that increases your chance of autoimmunity. But what then causes autoimmunity? Well, there are a couple of things, and this isn't just for cardiac. This is for any of your autoimmune patients. And it's kind of interesting that cardiovascular disease seems to be an autoimmune issue. So the first thing is molecular mimicry. So if you have a virus or if you have a food that looks very similar to a region on your body and you have leaky gut, then the body that will get into the bloodstream. Your body will attack that, and it will turn around and it will attack yourself. The other thing is, anything that changes the way that your tissue looks will increase your chance of your body attacking its own tissue. So when you're oxidizing, if you're starting to rust, that will now look foreign and the body will attack it. And if you're having too much sugar and you're starting to caramelize, then what's going to happen is your body's going to see that and it's going to attack it. So when you have autoimmune patients, and the last thing is toxicity. Toxins change the way our cells look, our tissue looks. And then there is the controversy of lectins. I think it may be true in some people, lectins may trigger like an autoimmune response as well. So lectins will go into the bloodstream and they will bind to different areas in the body, and then the body sees that complex and starts to attack it. So whenever you have somebody with autoimmunity, go back to the basics. That's what I love about functional medicine. I can go back, if it's cardiology or if it's immune or whatever it is, we can always go back to the basics and come up with a treatment plan. So what happens is, as the plaque continues to stabilize, or it continues to get bigger and bigger and bigger, and the progenitor cells are starting to deplete, you can start to calcify. And the calcifications, the calcium can when that starts to happen, it can actually poke through and tear holes in the lining of the blood vessel. So what can stop the calcification? There is a enzyme called matrix GLA protein, and its job, it is vitamin K dependent. So you need to have activated vitamin K in your system. But its job is to pump the calcium out of the blood vessel wall and pump calcium into the bones. So how do we get vitamin K? Leafy green and good bacteria. And we can treat people with menaquinone 7, which, as a matter of fact, a lot of my patients, instead of giving them just vitamin D, I give them vitamin D and menaquinone 7. Statins, they're interesting. There was a study that showed that statin drugs, that they end up causing the calcification of the blood vessel. But then the researchers said, well, this calcification may be a stabilization that shows how statins actually help and work. Or this calcification that the statins are causing, yes, you have a decreased risk of heart attacks early on, but they may increase your risk later. Who knows? So the unstable plaque can rupture. So how does the heart attack happen? The unstable plaque can rupture. There can be erosions that happen in the endothelial wall, or the calcified nodes can poke through. And what happens when you break that open and the inside of the blood vessel exposes itself to the lumen, to the inside of the blood vessel? So the inside of the blood vessel wall breaks and exposes to the lumen. Then what happens is a clot can form. And when a clot forms, if it forms too vigorously, you're going to block blood flow completely and create a stroke or a heart attack. There are other risk factors. If your fibrinogen is high, that increases, that's an inflammatory marker, but that increases clotting. So that's something that we check. We also, if you have elevated Lp(a), which Mimi is going to be talking about in a bit, this is genetically determined, and it can impede the busting of the clot. So it can make the clot stay longer. So that is going to be a risk factor as well. If the homocysteine is high, stay tuned for the genetics talk that I'm doing on day 3. I'll talk more about homocysteine and what to do with homocysteine. And then your omegas, if your omega levels are low, then you're going to have your body is going to clot a lot faster. And that also, if you have low omegas, that increases your risk of cardiovascular disease. So basically, here are all the labs that I talked about that you can check. And what we just did for you, you're welcome, is we took this panel and we turned it into this panel, which can trigger all kinds of emotions. And because I'm a trauma certified provider, I like the emotional thing. I think we got to get into our emotions more. So how about you put what emotions you're feeling right now in the chat box? You may be thinking, give me the blue pill. I just don't want to know what's happening. Sorry, by signing up to this course, if you're watching me right now, you already took the red pill, but it's not as bad as you think. What I do is first I relax. The fact that this is even being checked, the fact that we're even looking at this means we're way beyond our times. Do 1, 2, maybe 3 changes at a time, and that 1 or 2 changes or 3 changes will go a long way. You can make one little change and everything starts to look better. My sequence. So I look at a standard lipid panel, and if the LDL is elevated, then I'm going to look at ApoB and small density LDL. That's going to tell me the LDL burden. The next step, I'm going to look at A1C, C-peptide, insulin, and triglycerides. And if that's abnormal, that's where I'm going to focus. If A1C, C-peptide, insulin, and triglycerides are looking normal, then I'm going to look at other markers or other clues. And this is just for me to figure out what I'm going to go at first, because you make a change and then the patient gets better, and then you follow it, and then you fine tune it. So other clues, if they have oxidized LDL, F2 isoprostanes, work on antioxidant function. If they have myeloperoxidase, high sensitivity CRP, LP-PLA2 or fibrinogen, I'm going to work on inflammation. If they have abnormal HDL, ApoA1, HDL2, I'm going to work on increasing HDL. If they have LP-little-a, I'm going to target LP-little-a, and I'm going to be more aggressive about risk factors. If their TMAO is elevated, I'll consider decreasing meat, but I'm also going to work on gut and gut microbiome. If their homocysteine is high, I'm going to work on methylation and lowering the homocysteine. If their NT-proBNP is high, I'm going to rule out CHF. I'm going to work on sympathetic parasympathetic nervous system. I'm going to rule out atrial fib and sleep apnea. And if they have low EPA, DHA, replace it, get their levels up. So how do they relate to the functional medicine matrix? How do these risk factors plot? Here they are. You guys should have this. This is the cardiometabolic matrix filled out for you from a cardiovascular point of view. And this is the decision tree. And a quick pop quiz. This is rapid fire. Get ready to answer in your chat box if you're fast enough. How many times more atherogenic is small density LDL than large buoyant LDL? 1.7 times more atherogenic. What other lipid abnormalities is small density LDL associated with? Increased triglycerides, decreased HDL. This apolipoprotein is the primary lipoprotein of chylomicrons, VLDL, IDL, LDL particles as well. It's considered an independent risk factor for coronary artery disease. What is it? It is, can you type? It is apolipoprotein B. This urinary marker helps determine oxidative damage. What can you check in the urine to look for oxidative damage? F2 isoprostane. And now let's distinguish how a functional medicine approach is different when we're trying to reduce cardiovascular risk. So it's not that we order more tests. Before functional medicine, what I used to do is I would check labs and go right to the treatment and start treatment, right? But now what I do is I go right to the pathophysiology. A lot of times patients didn't feel better. They actually would say that they felt worse. And so the thing is, the definition of insanity is doing the same thing over and over, expecting a different result. And I couldn't keep doing it anymore. That's why I became a functional medicine provider. So the functional medicine approach is well said by Avicenna, the father of modern day medicine. Avicenna said that the knowledge of anything, since all things have causes, is not acquired or complete unless it's known by causes. Therefore, in medicine, we ought to know the causes of sickness and health. Knowing the why. The why is what functional medicine, the why empowers us to make more fine-tuned treatment plans. It improves patient compliance. Chat in the chat box if you know what I'm talking about. When you know the why, when you understand the matrix and you can explain it to patients, you get such a different effect. And listen, if you ever get overwhelmed, just look at the bottom of the matrix. Everybody needs to work on sleep. Everybody needs to work on exercise. Everybody needs to work on food. Everybody needs to work on stress and stress management and relationships. I remember back in residency, there was a patient that we had that he had multiple heart attacks. He had cabbage, he had stents, and he's sitting there and he just had another heart attack, and he's like desperate, and he looks at the attending and he's like then the attending tells him, "I'm sorry, there's nothing more we can do." And he looked at me after the attending left and said, "Should I just sit and wait to die?" And I wish I knew back then what I know now, because I wouldn't be speechless. I would have so many things to talk to him about. Before functional medicine, like I said, I would just go and follow the guideline, and that was it. I wouldn't think about the thought process, but really that is the easy road. The easy road is just following the guidelines and moving on. Medicine is expanding and time is passing, and it is easy to just follow the guidelines and just go play golf or something. But the fact that you're here means that you're not about easy. I'm not about easy. We're here because it is what is right. Guidelines are a starting place, but asking why is how we take things to the next level. Asking why is how we practice individualized medicine. Asking why is how we transform from a practitioner to a healer. And asking why is functional medicine. Thank you very much.